We were number one for years. We were the leaders in Caribbean medicine. We did the first open heart surgery. We did the first kidney transplant. We were pioneers in laparoscopic surgery. And then all of a sudden, over the last maybe 20 years or so, we have just lagged behind significantly. There are many reasons for this. We can look at healthcare financing. I think everybody understood that things started the downward spiral once we had this quote-unquote free healthcare without a substitute means of funding. But right now, Trinidad, I would safely say, is a leader in the Caribbean. When you go to a Trinidadian or Bajan hospital, it's like night and day. And when you compare our ivory tower of the University Hospital of the West Indies with their public hospitals, it's like night and day. And it's actually embarrassing when you go to conferences when they're presenting what they're doing as routines and we are presenting it as novel in Jamaica. Nobody cares that you're doing it for the first time in Jamaica when they're doing that 5 times a week in Queen Elizabeth Hospital or Port of Spain General. So we have lagged behind, and I think that our pride of place in the Caribbean is just no more, and we have to fix it.
As a university, we have to train more people, and there are many people in Jamaica who want to be trained. And I think as a university, we have a responsibility to give that access and to be aligned with the healthcare sector and the ministry, and to be agile enough, as I said, to ensure that we provide this care for the patients who need it, but also when our staff moves in a global era. And so you'll hear the university talk about the pillars of its strategic plan: access, alignment, and agility. And in this era, we've spoken about the revenue revolution and ensuring that we have modern equipment for the patient. And so the revenue, we can't forget, is also important to deliver care, because a lot of the intensive care unit equipment, as you know, is manufactured overseas and is imported along with the diagnostic. And so the university has to be operating within that space. And we have to be an intelligent organization in order to make sure that we're meeting the quality of care. In an era where technology moves at warp speed, we have to keep up in delivering that care for our patient.
Government leadership acknowledges the strain. Health Minister Dr. Christopher Tufton has argued that expanding hospital infrastructure will ease bottlenecks.
The Spanish Town Hospital build-out will provide more ICU/high dependency beds. Cornwall, when come back on stream, will also. Western Child and Adolescent, the new hospital, will also. There is an intention, as I have announced, to do a new KPH, starting with one initial block. UAE is pursuing its expansion mode. We do intend to look at Bernard Lodge for a new facility there. I'm not sure what that may entail because the design for that has not been completed. With those large buildings going up to serve larger urban spaces and with a sicker population or at-risk population, we will see more beds.
We have plans in place to improve our ICU services as we improve the service offerings that we have in the hospital as we move into cardiovascular care, interventional cardiology, interventional radiology, as we consider accepting extremely ill patients, cardiac patients, stroke patients, trauma patients. We know it is inevitable that we must have an ICU space, and it will only augur well to assist in ensuring that the number of bed spaces that are available island-wide, whether in the public or private sector, is enough to satisfy the population. So we have a medium-term target of 1 year. So by 2027, we intend to have this space operational. Initially, in our developmental plan, we intend to have a 5-bed ICU space, fully staffed with critical care nurses, and of course in partnership with our anesthesiology team here at Andrews. Of course, there's a wider plan to have a much larger space to deal with more intense illnesses.
My view on healthcare is that it is a combination of private and public. The more private options people have, the less stress on the public system. So whether it's Andrews or Mandeville or any other, we would encourage them to expand as much as possible, to offer more services, to offer more space, because we operate in a public-private environment.
Plans include facility upgrades, additional clinical spaces, expanded training, and overseas recruitment of nurses.
We have seen compensation review that has improved the salary for nurses and for all healthcare workers. And there are other things that are being done, like improving the working conditions through the build-out of new facilities that will hopefully contribute to retention. But even with that, I do believe we need to be able to train more. And I think also where we fall short with our population, we need to look to recruit externally. And that's what we have been talking about and doing. Sometimes it's not always about the salary. It's about working condition, it's about accommodation, it's about a range of things. And we're trying to approach it from a more holistic perspective, even though we're building out to improve conditions and offering through compensation review.
So you're looking to bring in critical.
If the need arises, you may recall that recently we advertised in the diaspora offering Jamaicans an opportunity to return if they have that inclination, because many Jamaicans are working overseas in that space. And we've had some inquiries, can't comment too much on it yet, but that we are doing as much as we can to take advantage of the locals wherever they are, whether in Jamaica or outside of Jamaica. But failing that, we have no choice. We're going to have to engage others.
You can't have 1 or 2 nurses doing 12-hour shifts back to back. It's just unsustainable. So you have more junior staff filling in. And the truth is that experienced nurses are what really run an ICU. And in the formal ICUs, we don't have enough experienced nurses. So you can just imagine what we have to contend with in the HDUs.
Yet, the Nurses Association of Jamaica NAJ has voiced concern, questioning whether infrastructural expansion without rapid workforce stabilization can resolve the emergency.
I would ask the government to really look at investing in health like it is said it should be. Because one of the challenges that, as the president of that I am seeing, the investment in health is a face card. The integrity of our nurses is being undermined. So when we talk, persons don't listen. You are not invited to the tables that nurses need to be. You cannot be operating a 24-hour healthcare delivery service and you make decisions outside of nursing totally. The nursing structure has leaders. We have our directors of nursing services. We have our senior public health nurses. We have our nurse practitioners. We have our nurse anesthetists. We have our mental health practitioners and so on. So we have persons who are clinically based and administratively based. Why would you be making plans and doing things external to nursing?
Us within a hospital setting, maybe a high dependency unit could assist us significantly because it would ease the pressure of admissions to an ICU. A high dependency unit is an intermediate care area between ward level care and intensive care. Intensive care is minute to minute, hour to hour, one-to-one bedside nursing with specialists, etc. Support service, dietitians, occupational therapists, physiotherapists, blood banking, radiography, etc., etc. A high dependency unit offers the patients an opportunity to be saved before they deteriorate. So maybe one organ system is compromised, but not 2 or 3. And so we can put the patient there, offer them some care so that they never need an ICU. Likewise, coming out of an ICU, we can step the patient down to that intermediate care so that all the efforts that we did in the ICU, we don't see them transition to the ward and then demise ultimately anyways, which tends to happen or can happen. So we find our ICU functioning somewhat like an HDU as well as an ICU because we tend to take patients before they even need us to ensure that they don't deteriorate to the point of needing maybe the breathing machine, etc. And then we hold on to patients longer than they need to be in an ICU, preventing the admission for another patient because we don't want to send them to an environment where they don't get that close nursing and observation. So high dependency units would help us.
I think the minister have given a comprehensive review of what he would like the institution to be like, even lifting it from a type B facility to a type A. Physical infrastructural changes are challenges that must be overcome. Also with technical support, meaning doctors, trained nurses, trained doctors that are trained for the intensive care setting. That in itself is a huge challenge to overcome. Because if you look at intensive care support throughout the country, there's always a lack of one member or the other of the medical emergency team that is needed to be in the intensive care unit at more established institutions. Now, to get that established in Salve would mean a lot of training, a look at personnel, changing the social amenities that would like to have to attract those level of technical clinical support to come to Savlamar to get an ICU up and running. Already, Savlamar suffers from a brain drain of doctors because you may go to Manning's High School or whichever high school within the parish and go to university and train as a doctor. But when you get back to Salve as an intern, most of our doctors want to leave. One of the reasons they want to leave is the same issue: lack of facilities, lack of ICU, lack of certain things within the hospital. Not to even mention, as I mentioned before, the social amenities. Are we able to have proper housing? Are we able to have proper entertainment? There are a lot of things that doctors look at when they're trying to come to Salve and find it very difficult to stay here.
In those situations, you can centralize, this is a neurology ICU, this is a general surgical ICU, this is a medical ICU, and you can separate the needs as per, this is a cardiac ICU, this is a cardiovascular ICU, etc. This is an oncology, so we deal with, maternity patients here, or we deal with solid organ tumors, transplant patients. So it depends. But in a mixed setting, they say about maybe 10% of the beds.
Behind the policy debates are families in corridors waiting for news.